Hi everyone, I'm Natalie, and today I'm going to be presenting this case study on a patient that I actually got to take care of at Children's Oakland with Bordetella Pertussis. Now, that's just a fancy name of saying pneumonia, but we will be going through the whole process of this patient's stay and their disease process and their history. So first I'm going to start with their history. This is a 6-month-old patient. They were born with a gestational age of 36 and 2/7 of a week. They were born by a C-section and they weighed about 2.67 kilograms. Baby was 48 centimeters long and they had an APGAR score of 8. There was no complications at birth. Now, at 2 months old, the patient was brought into the emergency department for increased work of breathing. Baby was throwing up, they had emesis, and their saturations were really low, around 70%, and they were not eating, they had no appetite. Now, upon arrival, the patient was placed on nasal cannula, and they quickly transitioned into heated high-flow nasal cannula on 10 liters, 30%. After getting multiple tests done and after being on heated high flow for a while, the patient was diagnosed with pneumonia after some ABF cultures were positive for Bordetella Pertussis, Streptococcus pneumoniae, and Klebsiella pneumoniae. The patient quickly progressed to having hypoxic respiratory failure and was intubated. RDS was also added to the patient's list of complications. RDS contributed a lot to their current condition. The patient did not show any signs of improvement and was later placed on ECMO. They were on ECMO for, I believe, around 2 months. Then they were decannulated and they transitioned into INO with an endotracheal tube. They spent months intubated, and the team thought about tracheing the patient, which the mother agreed to, and now is trached and preparing for discharge after being in the hospital for over 4 months. Now, I'm going to talk about the etiology and pathophysiology of the 3 main diseases that the patient was diagnosed with, starting with Bordetella Pertussis. The patient can get this by having bacteria transferred via droplet. We know that this patient was 2 months old but the time that they went to the hospital, which could mean that they did not receive any of their vaccinations, which does not create a strong immune system. So the weak immune system picks up the bacteria, and then the bacteria kind of builds up into their body, their bloodstream, which then kind of fights their healthy cells and gives them whooping cough, respiratory infection, severe coughing, and then all of those are categorized into a disease which is known as pneumonia, and they're diagnosed with it and further actions taken upon there. Patient was receiving antibiotics, patient was receiving constant pneumonia prevention, and then the patient was also diagnosed with respiratory failure, to be specific, hypoxic respiratory failure. And we know that this is very common with patients with pneumonia because pneumonia kind of blocks their gas exchange, leading for them to not have any oxygen going in. So the way this starts is that their immune cells attack the germs, and we know that they had that bacteria in there. So the body's immune system naturally causes inflammation to try to fight the bacteria. Because of this inflammation, the lungs fill up with fluid, the alveoli fills with fluid, and that interrupts gas exchange. We know by Fick's law that a thick membrane cannot be permeable with oxygen and carbon dioxide because there is something in the way. The patient was then hypoxemic, and which led to hypoxemia, respiratory failure. And then for RDS, which stands for respiratory distress syndrome, it's basically when a premature baby was born with either less or not enough surfactant. We know that premature babies aren't fully developed, so their lungs aren't fully developed, so there's going to be some missing factors or things that can not be developed properly. So because they aren't born with sufficient surfactant, we know that surfactant prevents the alveoli from collapsing. It breaks down that tension. So this patient had RDS, less surfactant, their alveoli were collapsing. Because their alveoli were collapsing, they're not able to get that oxygen in and push out that CO2 like fast enough, so their work of breathing increases because they're trying to grasp onto as much oxygen as possible and get as many breaths in. They're not able to obtain that oxygen. Because they're lacking oxygen, they become hypoxemic, and then they become hypoxic respiratory failure. So we know that these three disease processes were what made our patient sick. And further along, we will be talking about things such as contributing factors, respiratory treatment plans, clinical data, and then emerging therapies, leading with the conclusion.
Hello, my name is Carlos, and I'll be presenting pertinent clinical data. Um, we'll take a closer look at the clinical data that gave us a clear picture of how critically ill this patient was. And I'll begin with her chest imaging, and then from there we'll go into ABGs, some labs, and some cultures. First, here we have some of a chest X-ray that revealed bilateral peripheral infiltrates, hyperinflation, air trapping, and areas of atelectasis. These findings are classic for RSV bronchiolitis, but in this case they were worsened by the pertussis and secondary bacterial infection. Hyperinflation and atelectasis indicate poor gas exchange and increased work of breathing. Major contributors to her respiratory failure and eventual need for mechanical ventilation. Next, we have some one of the arterial blood gases. Her ABG showed she had a pH of 7.31, a PaCO2 of 59, a PaO2 of 70, and a bicarb of 26, with an SaO2 of 93. This indicates acute respiratory acidosis with mild hypoxemia. The elevated CO2 shows that she was not ventilating effectively, which reflects respiratory muscle fatigue and airway obstruction. Next, we have some laboratory results. As we can see here, she had a white blood cell count was 18,000, confirming her systemic infection, a hemoglobin of 10.2, suggesting some mild anemia. Platelet count was normal at 210,000, and her renal function and electrolytes were within normal limits also, which is reassuring in a critical ill patient. Her glucose level was 110, indicating stable metabolic function. Also, we had a nasopharyngeal swab that tested positive for Bordetella Pertussis and RSV, both serious infections in infants. Her sputum culture grew Haemophilus influenzae, which was sensitive for ceftriaxone. This co-infection significantly increased her risk for severe respiratory decompensation, explaining the need for aggressive interventions like mechanical ventilation and ECMO. So now we transition to emerging therapies. This clinical data paints a clear picture of why she deteriorated so quickly. Now let's take a look at the emerging therapies that are transforming how we treat and prevent these life-threatening infections. First of all, we have nirsevimab, Beyfortus. This is a long-acting monoclonal antibody designed to prevent RSV infections in infants. Unlike palivizumab, which requires monthly infections, this is a single-dose therapy that protects throughout the RSV season. Clinical trials shows it reduces RSV-related hospitalizations by nearly 90%. This is especially significant in cases like ours, where RSV co-infection worsened the clinical course. Next, we have maternal RSV vaccine, Abrysvo. Abrysvo is an RSV vaccine given during pregnancy to protect newborns. It stimulates the mother's immune system to produce antibodies, which are passed to the baby. This has been shown to reduce severe RSV illness in the first 3 months of life, which is the most vulnerable period. If used more widely, this could prevent hospitalizations and reduce the need for intensive interventions like we saw in our patient. Next, we have ECMO. ECMO is a life-saving intervention used when mechanical ventilation is not enough. It provides oxygenation and CO2 removal externally, allowing the lungs to rest. In this case, ECMO was used due to severe hypoxemia and ventilator failure. What's emerging is the expanded use of ECMO in pediatrics, with improving outcomes even in complex cases like RSV and pertussis co-infection. Centers are also improving protocols for weaning and reducing complications like bleeding or infections during ECMO support. Next, we have the high frequency jet ventilator. The high frequency jet ventilation is an alternative ventilation mode that delivers small, rapid bursts of gas to minimize barotrauma. It's especially useful in cases of air trapping, severe bronchitis, or when traditionally ventilation causes lung injury. In our patients, it was considered due to persistent hypoxemia and hypercapnia, despite standard ventilation settings. This therapy is increasingly being used as a bridge before ECMO or in combination with inhaled nitric oxide for severe pulmonary hypertension. These therapies represent hope and innovation for critically ill infants. Now let's wrap up with the key takeaways in case and what this case has taught us today. To conclusion. To conclude, this case demonstrates how complex and multifactorial pediatric respiratory failure can be. Our 6-month-old patient faced severe challenges: Bordetella Pertussis, RSV, bronchiolitis, and chronic lung disease, ultimately requiring intubation, ECMO, and tracheostomy. Thanks to the comprehensive respiratory management and advances in therapy, she is now clinically more stable. Her ABGs and ventilator settings reflect gradual improvement, which is promising. What gives us even more hope are emergent innovations like NAVA, monoclonal antibody protection, and more refined ECMO protocols that are shaping the future of care. In the end, the most important takeaway is that interdisciplinary evidence-based collaboration is what makes survival and recovery possible for a patient as fragile as this. And this concludes our presentation. Thank you for watching and tuning in. Thank you.
Contributing factors. This infant presented with severe respiratory failure was caused by a combination of pertussis and RSV. These infections trigger significant airway inflammation, mucus plugging, and hypoxia, which eventually leads to mechanical ventilation and ECMO. In the upcoming slides, I'll focus on what factors led to such a critical outcome and how we currently support her ventilation and oxygenation. Because this infant had not completed her DTaP series, she lacked immunity to pertussis. Infants have naturally smaller airways, so any inflammation or mucus production can significantly increase airway resistance. Their immune system are also underdeveloped, which limits her ability to clear respiratory pathogens, in return increasing the risk of severe illness. There's a little graph below shows the comparison of an infant airway to an adult airway. On top of pertussis, she also was tested positive for RSV, which is common in babies and often leads to bronchiolitis. That also means that the airways are inflamed and they're filled with mucus, which makes gas exchange very difficult. And because infants don't produce as much surfactant, their lungs are less compliant, which increases the work of breathing and lead to respiratory distress syndrome. Prolonged mechanical ventilation and sedation suppresses the infant's natural cough reflex, also mucus, to accumulate and increasing infection risk. ECMO becomes necessary when mechanical ventilation fails in this case, but introduce further complications. So ECMO can cause bleeding and also delay lung healing. Nutritional support was also compromised, weakening her immune system. The GI bleed is likely resulted from stress, ulceration, anticoagulants, and NG tube use, which further destabilized her already weak condition. So these are the current mode that she's on. She's on pressure control ventilation via tracheostomy. And these settings are chose based on lung protective strategy. We use pressure control to limit peak pressures, which reduces the risk of barotrauma. And FiO2 is titrated carefully to avoid oxygen toxicity while keeping SpO2 above 90%. PEEP is kept around 6 to 8 centimeters of water, and an adjusted IE ratio allows for better exhalation, which reduces air trapping. Permissive hypercapnia is accepted here to prevent ventilator-induced lung injury as long as the pH stays above 7.25. We aim to keep oxygen saturation above 90% without exposing patient to too much oxygen. Heated humidification keeps secretions thin, and inline suctioning helps remove them without circuit disconnection. Also, inline suctioning and frequent repositioning can improve ventilation perfusion matching and reducing lung collapse. Here are some of the medications and GI management plans. She is currently on albuterol to help open up the airways and corticosteroids to reduce inflammation. Also, they got her cultures results, so they adjusted her antibiotics. She's also on medication to protect her stomach and prevent another GI bleed. Now that she's more stable, the focus is shifting to weaning her off the ventilator. She's doing this slowly by lowering the FiO2 and respiratory rate while watching her closely to see how well she can breathe on her own. They also monitor her spontaneous effort, basically checking if she's initiating any breaths and whether those breaths are effective in terms of volume. To help with this, they are tapering down her sedation. If she's too sedated, her drive to breathe can be suppressed. So reducing medication lets her body take over more of the work. This also helps assess her neural status and readiness to interact with her environment again. Another key part is avoiding complications. When someone's been on a ventilator for a long time, the diaphragm can weaken and the areas of the lung can start collapsing. So, in order to prevent this from happening, we need a good mobilization, good nutrition, and careful monitoring. The bigger picture includes getting her off the trach and whenever she's ready and helping her lungs recover through pediatric pulmonary rehab.